Hello, welcome back. We're finally getting to the cyanotic congenital heart defects. This one is on tricuspid atresia. Let's get on into it. So, first thing to know, tricuspid atresia is one of the most profound cyanotic congenital heart defects, and it has a very classic single ventricle physiology. What this means is there's no tricuspid valve, so blood can't flow from the right atrium to the right ventricle. Because blood can't enter the right ventricle, right ventricle becomes what we call hypoplastic. Then pulmonary blood flow is going to be severely reduced, and that's going to lead to obviously profound cyanosis. And all in all, I want you guys to remember this. It's going to sound very strange, but survival is dependent on mixing. So if we're not mixing our blood, and what I mean by that is going from obviously deoxygenated to oxygenated, right? They're not going to make it. So an ASD can be helpful in that systemic venous blood flow so that they can get blood to that left atrium. And a VSD or a PDA is also helpful. So this is a condition where you kind of want a hole to help with the blood flow. You want an ASD, you want a VSD. Any of those um, acyanotic defects that we talked about, you kind of want them here just to help with that flow. All right, clinical features. Obviously, we talked about that profound cyanosis. You're also still going to see the tachypnea, the poor feeding, the fatigue. You can also see hepatomegaly, but this time it's going to be from chronic hypoxia and less about the increased systemic pressure, but the increased systemic pressure can also cause it. And then over time, if it's left untreated, they can end up with polycythemia or clubbing. So treatment, it's beginning immediately. We're doing prostaglandins to keep that PDA open because again, we want to maintain that pulmonary blood flow. If they have an ASD that's restrictive, we're gonna do a atrial stepostomy just to help improve that mixing. We're gonna monitor for arrhythmias after they've had that post-op, low cardiac output, and any changes in oxygenation, even good ones, right? Because we want to see it, we do want to end up seeing a change because we want them to be less cyanotic. So we're also looking for positive changes. Hopefully that makes sense. And then the surgical pathway itself is following a very specific kind of sequence. So stage one is when you're having a neonatal shunt or a BT shunt. It's based on whether it's ductal dependent or not. Stage two is called a Glenn procedure. Um, you kind of trying to explain. Well, I don't think you guys really need to know it, but you're going from that um the current defect to something else just to help with that mixing of blood. And then you have the Fontan procedure. Hopefully that makes sense. I could put it in the description, but I made this on how I was tested on the material. Let me go back. I made this on how I was tested on the material. This is in the book that I used all throughout nursing school. It's in the book, but it doesn't actually kind of like explain what it does, but I can put that in the description for you guys. All right, nursing care. So it's continuous, it's meticulous because you have to make sure that we are monitoring that oxygen status because yes, they'll have some cyanosis, but they should be stable as well. So we're looking at feeding intolerance, respiratory effort, their growth trends as well. We're going to monitor for heart failure signs and symptoms and increased work of breathing. Pre-cath allergy checks, baseline pulses, NPO. After that cath, we're clustering care. We're watching for arrhythmias. We're checking distal pulses, monitoring for bleeding, and keeping that leg straight. All right. Parent teaching, we're teaching them, we're monitoring for, you know, increased work of breathing, poor feeding, worsening cyanosis is a big one. We're going to explain the whole thing to them super simply. They don't have a tricuspid valve, so they can't, their blood flow can't go to that right ventricle. So the surgery is going to help kind of create a new pathway for their blood to reach their lungs so that they can, you know, breathe and not be blue. Um, we're reinforcing those scheduled surgical stages and consistent cardiology follow-up. We're going to avoid strenuous activity every single time we have that any surgery, watching for fever, chest pain, palpitations, and obviously endocarditis prophylaxis if it's necessary. All right, resources, and that's it for this one. All right, I'll see you guys in the next one. Bye.